Yeah, trendsetter, whoa, league of my own, it don't get better. No, read what I wrote, I'm a bestseller. Yeah, reach for my goals, hit it dead center, hit it dead center. Bullseye, hit it the most, there's no misses. Something like fish in a barrel, it's no different. Blindfold on me, I still got the most vision. Trendsetter total.
We have epidermis, basal layer, dermis and adnexal structures. So we will go through each of the layers which gets affected by the tumor cells. So when we go with the history, we need important details by collecting the history. So what are all the details which we ask them is like what is the present issue, whether the dog had a concurrent diseases or a concurrent issue, whether the dog had a vomiting episodes or a melena, particularly melena in case of mast cell diseases, vomiting, or some of the clinical signs which may be associatedly present. So questions which are to be asked to the owners, which are very important, are the time duration, whether the size is increasing or whether it is decreasing, and at what rate the increase is, whether there was a cutaneous lesion before or whether there is no cutaneous lesions or there was lesion somewhere else in the body, and if it was sampled earlier by any other vet or whether it has been sampled earlier, and if it was sampled, what was the diagnosis? Then you proceed on to clinically examine the animal and you look for where it is, how large it is, and you also do the measurement. You also check whether it is circumscribed, whether freely movable. If it is freely movable and well marginated, it might be benign tumors, and if it is invasive and fixed to the adjacent tissues with poor margins, it might be a malignant tumor. Skin tumors are primarily primary tumors basically, and some of them have a secondary metastasis, and some of the internal tumors may also manifest on the skin at later stages. So you may have to look which came first and hunt for the primary tumors. So what else to look for? You also need to check organomegaly. You have to check for any dyspnea. This gives us a clue about any distant metastasis. For example, cutaneous TVT, there could be a organomegaly, there could be a splenic metastasis, or there could be a liver metastasis. Sometimes there might be a lung metastasis also. So we need to look for organomegaly and dyspnea when you're doing a clinical examination. So diagnosis, when there is a lump or bump, just we are not supposed to ignore. So we go for a fine needle aspiration. And in a fine needle aspiration, we have core techniques and aspiration techniques. In biopsy, we have incisional, excisional, punch biopsies. Core biopsies, we also have share biopsies. And once the biopsies are done, we can go with immunohistochemistry and various staining techniques. And we obviously we need to go for X-ray, both chest and abdominal X-rays. We need to do an ultrasonography if needed. Now CTs have come into the play. We have to go for CT and MRI in cases and when it is available at our dispense. So coming to fine needle aspiration, core technique is like you hold the lesion between your finger and thumb, use a 23 gauge needle into the lesion, angle the needle into different areas. Here you can notice that I am not attaching any syringe to it. So only the needle is used and 23 gauge needle is more than enough. And remove the needle, fix a 5 ml syringe with air to the needle hub and expel the contents onto the slide. Make a smear. Here you have a less blood contamination, but the cell harvest may be very low. So this might yield a preliminary investigation for you. So this can be done at your facility itself. When you have a stain and when you have a microscope, you can just see into it. And if you, in case if you have a doubt, you can send it to the pathologist. So aspiration technique is another one wherein which you will hold the lesion between the finger and the thumb, attach the syringe to the needle, pull back the syringe and angle the needle at various areas of the mass. Then you have to disconnect the syringe and fill the syringe with full air, reconnect it and expel the sample onto the slide and make a smear. So this is aspiration technique. When we go for excisional biopsy, you can go with whole excision or you can go with a part as incisional biopsy and then send it for a histopathology. And punch biopsies, there are two biopsies that are available. One is reusable, another one is disposable. They are available at various sizes, but whenever I am sending a sample to a pathologist, they look for a bigger sample. So mostly I use 8 punch biopsy punch biopsies. 8 I use, and when it is going to be near the nose, ear, or foot pads, then you can go with the smaller sizes. So here you need to slightly go and infiltrate the area with lignocaine. Usually lignocaine with sodium bicarbonate, they tell that using a sodium bicarbonate will reduce the lignocaine tinge or pain due to lignocaine. So you can infiltrate closer to the lesion, and then you can use the punch biopsy instrument to use to collect the samples. So here you don't need much of a big technique. Only thing is you need to place a stay suture and ask the owner to come after 4 or 5 days to remove the suture material and send the sample for the histopathology. It's a very easy one, and the sample size is better when you are taking at 8 as I told before. Another one is the core biopsy or the true cut biopsy needles, which can be used in bigger masses wherein which you are unable to do a excisional biopsy or incisional biopsy or a punch biopsy. You can go with a needle core biopsy or a true cut biopsy. In this technique, it's likely that you may spill the tissue or the sample into the body itself if you are not having a proper like experience in using a true cut biopsy needle. So these are true cut biopsy needles. It requires little skill to use these needles. These are disposable core biopsy instruments. These are called as biopsy guns. Here the missing of samples will be avoided because this automatically goes and locks the sample into the instrument so that you will not miss the sample. So it is always better when you are going to go for a bigger tumor size and you want a tissue sample, you can use this core biopsy instrument. It will cost you around 2,500 to 2,800 on MRP. So this is reusable in case if you are frequently having a cases, you can use this reusable biopsy gun, but it is really expensive. So I would always advise you can go with the disposable biopsy guns rather than these reusable guns, because it has reusable needles which cost around 1,400 rupees each time when you are using, and the gun itself will cost you around 1 lakh. So it is better you can go with biopsy guns. So another one is a shave technique. Here you are going to scrape the superficial areas. You can also use the slide edge to collect the samples. So this can also be sent for cytology. So as Dr. Nagarajan was speaking, nowadays things are being made easy because of the advent of AI. Even Zoetis had launched one of the slide readers which is enabled with AI. So it will be telling you the results. It's not too far for us to fetch them, and they will be coming in at a lower cost. So as of now, we have to rely more on the pathologist and our own skills. So we need to know little until these things come to us of better use. So coming to the type of tumors, we have epidermis. In the epidermis, we have basal cell tumor, which is now called as trichoblastoma, squamous cell carcinomas, and in case of dermis, blood vessels, hemangioma, hemangiosarcoma. Pericytes, we have hemangiopericytoma. Connective tissue, we have fibroma, lipoma, and soft tissue sarcomas, which are metastatic. Adnexa, we have hair follicles, pyeloma, trichoma, trichoepithelioma. Sebaceous gland, we have adenomas, sweat gland adenomas, anal sac adenomas, and others we have adenocarcinomas as malignant ones. So coming to others, if it is of lymphoid origin, we are going to have a cutaneous lymphomas and plasmacytomas. Mast cells, we have compact mast cell tumor, which are easily resectable. We also have diffuse mast cell tumor, which are going to be really aggressive. Histiocytic mast cell tumors are also there. Melanocytes, if melanocytes are involved, we get melanomas and malignant melanomas, which are going to be really difficult to handle. Macrophages, we have histiocytoma and malignant histiocytosis. So we'll go one by one into them. Before that, we have staging. You all might be doing the staging, but still I would like to tell you, like, you need to stage your tumors. So staging is based on the involvement of the nodes and the size of the tumor and tumors invasion. So invasion of the tumors and its metastasis. So TIS is a pre-invasive carcinoma, that is carcinoma in situ. Very superficial tumors that does not go reach the basement membrane. T0 is no evidence of tumor. T1 tumor no more than 2 centimeter in diameter. T2 is more than 2 to 5. T3 is over 5 centimeter. And there is an invasion to the subcutaneous. T4 is invading the other structures like fascia, muscle, bones, etc. And coming to stage, just based on the lymph node, we have N0, N1, N2, and N3. N0, no evidence of a regional lymph node. N1 is movable and ipsilateral nodes. And nodes containing growth and nodes not containing growth is classified as A and B. N2 is movable, contralateral or bilateral nodes, and N3 is fixed nodes. Why is this important to classify is, so nowadays we have a specialty practice that is coming up, and once you diagnose and you want to send them for a radiation or a chemo, radiation therapy or a chemotherapy, you classify the tumor, it will be easy to proceed on further. So coming to epidermis, we have the sun exposure and actin keratosis, wherein which the layers which are exposed are getting insulted, and they develop in situ carcinoma, which slowly becomes aggressive and starts to get invading inside. So mostly light skinned dogs like your Rajapalyam breeds and whiter dogs like Great Danes that are white colored white colored boxers, and these dogs are more prone for these kind of tumors. So basal cell tumors is mostly benign. You can see the lesion on the side. It is a very small erupted area, and it is simply looking as a papule, and there is no hair into it. And when you aspirate and see, you can see the cells being aligned. There is no metastasis or a sign of metastasis in this smear. So you need to go for when it is not interfering with any of the activities, it can be left as such. But if you want to remove, then you can go for a surgical removal with a complete margin in case if you require a surgical excision. So squamous cell carcinoma, it is again malignant, and they are present in mandible, maxilla, retrobulbar area, oropharynx, and trachea. And in case of cutaneous cases, we have it in nasal planum, ear pinna, and it sometimes be multifocal. So behavior is locally aggressive, low metastatic. Oral lesions are more aggressive than the cutaneous lesions. So staging, we need to go for a thoracic radiograph. You also need to check, as I told you, you need to check for the lymph node aspirate. You need to go for a CT scan. And in case if you are looking for a scaly, scabby lesion on the skin, it is a warning sign and it is a wake-up call that you need to do cytology and diagnose it and go for the earlier intervention. So cytology, you can see a perinuclear halo on a Giemsa stain. And in case of histopathology, you can see beautiful squamous pearls on the histopathology. So primarily you go for surgery if the lesions are too small. If in case after surgery it needs a radiation therapy, you can go for a radiation therapy. If it is thought to be like you didn't do a complete resection or it was a place where you could not do a complete resection, then you can go with the radiation therapy. And as we were been talking, this strontium 90 is a locally placed therapy. It is placed on the skin. It is used for various tumors, including squamous cell carcinomas, hemangiosarcomas, melanomas, and papillomas. This strontium 90 is just kept on the superficial area so that it directly acts on the layer and it does not go very deep into the skin. It only acts on the tumor cells. So photodynamic therapy, again, light-based therapy can be applied. Electrochemotherapy, wherein which chemotherapy and electrical activity are combined together. These are used in case of local options. Topical is imiquimod is one of the creams that are available at 5% creams. This is used for early and superficial lesions. You cannot use it when the lesion is very extensive. So this is one of the best creams that are available for various other things. When we are going through, I'll tell you the use of imiquimod in various other tumors also. So mitoxantrone is one of the anthracinidione anti-neoplastic agent. It is also very useful in the treatment. It is used at an effective dose of 6 milligram per meter squared IV every 2 to 3 weeks. So availability is 10 milligram, 20 milligram, and 25 milligram vials at a concentration of 2 milligram per ml. This product does not require any dilution. You can give it directly. And once you are going to use this, you have to warn the client that the urine might take a bluish green color for a maximum of 48 hours after having taken the treatment. So this is one of the chemotherapy that can be used. So other than this, we can also go with NSAIDs in the treatment of squamous cell carcinomas. Firocoxib is used at 5 milligram per kg until the complete clinical remission. So chemotherapy can be used after surgery as an adjuvant, and the most often preferred drug is cisplatin and carboplatin. But cisplatin has a lot of side effects. As you know, they have a lot of issues with renal failure, and we don't use it in cats. And instead of that, we can go with carboplatin, which is little safer. But the dosing here is like when you compare both are platinum group of drugs, but when you are using cisplatin, it is 50 to 70 milligram per meter squared. When you are using a carboplatin, it is 200 to 300 milligram per meter squared, but it is really safe when it is used. Coming to dermis, we have dermis blood vessels. We have hemangioma, which is benign. Usually in lighter skinned, thin coat dogs, they are mostly prone for it. Hemangiosarcomas are malignant. These things can be removed by surgical excision if it is in case of benign. You can also go with carbon dioxide laser ablation or cryotherapy. Here, in case of malignant invasive tumors, mostly they are because of sun related issues. And again, in these cases, we can go with surgical. We can also go with radiotherapy, electrochemotherapy, cryosurgery. Systemic treatment can also be attempted, and metronomic chemotherapy, which is taking a very big play in human medicine as well as in in veterinary medicine. So nothing but like it is using a low dose of chemotherapy for a quite a longer period without any much side effects. So here for hemangiosarcoma malignant, the chemotherapy protocol is suggested as VAC protocol. The VAC protocol combines like doxorubicin, cyclophosphamide, and vincristine. Before you start the chemotherapy, you can go with diphenhydramine at 2.2 milligram per kg intramuscularly given at 20 minutes before the treatment to prevent any anaphylaxis due to doxorubicin. But if you are already used and if you don't find any difficulty, you can directly go with it. Doxorubicin is used. This is a combination protocol. VAC protocol is you use doxorubicin at 30 milligram per meter squared IV, diluted at a concentration of 0.5 milligram per ml in sodium chloride and administered very slowly over 20 to 30 minutes on day 1. So again, cyclophosphamide at a dose of 100 to 150 milligram per meter squared intravenously, diluted at a concentration of 10 milligram per ml in sterile water. It is administered over a period of 10 minutes on day 1. So doxorubicin and cyclophosphamide are used on day 1. Vincristine is used at the dose of 0.75 milligram per meter squared intravenously at a concentration of 0.25 milligram per ml in normal saline. It is administered as bolus and it is used on day 8 and day 15. The cycle is repeated every 21 days. So this is one of the protocol, and once we see a remission, then we can go with a maintenance therapy. Maintenance is using a chlorambucil at 20 milligram per meter squared every 14 days orally, and methotrexate at 2.5 milligram per meter squared orally twice weekly. So this can be used as a maintenance therapy. Coming to AC protocol. So AC protocol is day 1 you use a doxorubicin and days 3 to 6 you use cyclophosphamide. Here you can see in the previous protocol the cyclophosphamide was used at 10 to 150 milligram per mg meter squared. Here we are using 50 to 75 milligram per meter squared and it is oral. There we used it as intravenous. So this is AC protocol wherein which we are going to use doxorubicin and cyclophosphamide. And this treatment is repeated every 3 weeks, which constitute one cycle of a chemotherapy. So doxorubicin plus or minus cyclophosphamide. Here you use surgery plus radiation. So after surgery, you go for a radiation. And then you want to select a chemotherapy protocol, then you can go with the doxorubicin and cyclophosphamide. If the dogs are weighing more than 15 kg, doxorubicin is dosed at 25 to 30 milligram per meter squared every 2 to 3 weeks. If the dogs are less, then it is less than 15 kg, then we use 1 milligram per kg of doxorubicin. So this is doxorubicin is based on the dog's weight. Okay. Then we go with cyclophosphamide. Whether the dog is more than 15 kg or less than 15 kg, we are now going to include cyclophosphamide orally on 3, 4, 5 and 6 at 50 milligram per meter squared per day in most of the dogs. So we are going to combine doxorubicin and cyclophosphamide as orally. And concurrently, we are going to use daracoxib at 1 to 2 milligram per kg once daily continuously in some dogs. So if we are going to get a clinical remission, then it's going to be good. But they are all therapeutic agents. So we need to be very cautious to look to evaluate at weekly intervals of blood, routine blood sampling. So coming to metronomic chemotherapy, which I was discussing earlier. So it is a frequent administration of chemotherapy drugs at low doses below the maximum tolerable dose and with no prolonged drug-free breaks. For example, if we are going to use a regular protocol, we give a drug-free breaks. For example, in case of CHOP protocol, the 5th week, 10th week and 15th week will be giving a gap. So here in this therapy, we are not going to give a drug-free break. and it achieves a sustained blood levels without significant toxic side effects. So, comparing the conventional and metronomic, cytotoxic drugs are designed for MTD, whereas here it is low. Here it is weekly or every other day or daily you can use, but in case of conventional, you will be using it 3 weekly, fortnightly, or weekly. So there is a rise and fall of plasma concentration in conventional, but in case of metronomic, it's going to be a sustained plasma concentration. So it has a lot of better advantages compared to the conventional one. And it acts by targeting the angiogenesis. They don't directly go and kill the tumor cells, but they target the angiogenesis. And low blood levels of the drug without clinical side effects or toxicities. So, what are all the drugs that can be used in our practice, like in veterinary practice for this metronomic chemotherapy? Cyclophosphamide, chlorambucil, and lomustine can be used with a good tolerance. So, these are the few drugs that have been dealt with in metronomic chemotherapy. Preventive measures, as I told, restriction to sun exposure. You can use sunscreens and protective clothing, constant monitoring of the animal for the emergence of new nodules if it has already been treated. So coming to another dermis related issue is the hemangiopericytoma. So there is a small nodule over here. You can see on the lateral near the thigh region. And here you can see the fibrosarcoma on a HP. It looks like a fingerprint. So this is a very typical appearance of hemangiopericytoma on a HP. So coming to cytology, how does this hemangiopericytoma looks? Is like they have a crown cells. Sometimes they have, you can see like a dragonfly eyes. You can see the nucleus that is like an eye of an insect. So these are few of the cytological findings. So here, what do we do? Is like we can go with radiation therapy. So hemangiopericytoma can be treated with radiation therapies like 200 to 300 kilovoltage peak ortho voltage X-ray therapy unit, and this copper is being used. And here you can also go with centigrade of fractions, and it can be treated with a radiation protocol. And after radiation, you can go with a heat therapy. So this can be done, but only thing is like sitting in a remote place, it is very difficult for us to go with a radiation therapy. So in case if you are not able to go with the radiation therapy, then we can go with bevacizumab. It is again a monoclonal antibody therapy. It is being used in human medicine, and it has also been found to be very good in veterinary practice, wherein which there is a vascular endothelial growth factor overexpression is being targeted in case of this particular drug, and it has been tried and found to be effective. It is available in the human practice. So coming to the connective tissue related masses, we have fibroma and lipoma. These are mostly benign and usually gets surgically resected if the owner is willing. We also go with surgery, or sometimes we go with cryosurgery. In case of if they are rapidly growing and if it is going to be a malignant, then we cannot go with complete surgical removal, or sometimes it is not possible even to remove surgically when it goes very extensive. So in such cases, we need to go for chemotherapies. So these are few of the cytology. Again, here you can see the spindle shape of the fibroma, and you can also see cells that are spindle shaped, round to oval nuclei, and purple wispy cytoplasm, and you can see there is a light pink extracellular matrix here and there. So here also you can see a typical crown cell. So what do you do when there is going to be sarcoma like this? Then you just check whether it is resectable, amenable to surgery, And if it is why the margins are okay, then you can go for surgery. If it is not, then you can go with radiation so that you can bring down the size and then go for a surgery. And if it is not amenable for re-excision, again you go for a radiation. If there is a good clean surgical margins, then go for a surgery. If it is a high grade, then after surgery you have to recheck every 3 months. If it is high grade and it requires a chemotherapy, you have to go with a chemotherapy. So what are all the chemotherapy agents that are being used is doxorubicin. You can also go with carboplatin, which is very safe. You can also go with drugs like ferrocoxib, NSAIDs, and metronomic chemotherapy in such condition. Coming to tumors of adnexa, we have hair follicle, sebaceous gland, sweat gland, and anal sac. And here we have, as we already discussed, piloma, trichoma, trichoepithelioma. These are easily surgically removed if the owners are willing. And in case of malignant, it is going to be adenocarcinoma, which requires again a radiation therapy or a chemotherapy. So in few of the cases which we had in our clinic, we had few of the adenomas which had been treated successfully, few of the adenocarcinomas which were not amenable for chemotherapy also. So sebaceous gland hyperplasia and eosinophilic secretions can be seen on the histopathology samples. So basically they are because of a lot of skin irritation. There might be a temporary discoloration and allergic dermatitis due to exposure to paint. These are most of the reasons why the dog tends to get these lesions. And treatment is aimed at oral vitamin A as an adjunct treatment for sebaceous adenomas, and the isoretinoin is also used, and we have successfully used in few cases. There were few cases that did not respond for this isoretinoin. A mixture of salicylic acid and lactic acid for external application did a better job in few of our cases. So this is available at Selectin Paints, which has salicylic acid and lactic acid combination. So this can be tried to be applied externally. Only thing is it is highly irritant, so you should not apply it on the normal skin. So whenever you are applying, you have to tape the adjacent area so that it doesn't move. Put a e-collar so that the animal doesn't turn back and leak. So coming to other tumors, we have mast cell tumors. Mast cell tumors is a malignant tumor that arises from the dermal tissue mast cells, and it is most common cutaneous tumors of the dog, and they are present in various places in various ways, and often cytology gives a clue. Still, we need to go for histopathology. Most often, we go for a complete removal, excisional biopsies. As these are few examples, you can see the lesions here on the dorsum of the dog, here again on the lateral aspect, here near the neck. So this was aspirated. So here you can see under the eyelid. So these are mast cell on a site on diffuse stain and cytology. These green arrows depicts the neutrophils. So these are the mast cells, and mast cells are having an eccentric nucleus, well-stained cytoplasm, and these are the this big yellow mark indicates the metastasis. So grading comes an important point when you are going to deal with mast cell tumors. Grading is based on Patnaik grading scale, which is grade 1 is well differentiated and mature. So again, this is on the histological basis. So how important is histology is you might be knowing. Coming to the second one, intermediately differentiated grade 2. Here you can see the mitotic figures are infrequent, more granules than anaplastic. When coming to grade 3, anaplastic, immature and undifferentiated, you can see lot of mitotic figures in each of the field, and edema, hemorrhage, necrosis, ulceration are commonly seen. So grading based on the histology, you do it 1, 2, and 3. Coming to the clinical staging, it is 0 to 4. So one neoplasm incompletely excised from the dermis. So without any regional lymph node involvement is 0. One neoplasm confined to the dermis without regional lymph node involvement is 1, and one neoplasm confined to the dermis with the regional lymph node involvement. Multiple dermal neoplasms or large infiltrating neoplasm with or without regional lymph node is 3. Any neoplasm with distinct metastasis, including blood and bone marrow involvement or recurrence with a metastasis, is staged as 4. So solitary tumors, surgical excision is minimum 3 centimeters, as Dr. Nagarajan told in the introduction. So initially it was 2 centimeter margins. Now it has come to 3 centimeter up to 4.5 centimeter. The surgical excision margin is being even up to 4.5 as per the recent literatures. So surgical removal is better if it is operable. If it is extensive, then it is very difficult to handle these cases. So post-operatively, you have to examine every 2 to 3 months. Radiation therapy prolongs the disease-free interval of incompletely excised tumors. So again, in case if you're not going with proper excision or the tumor is at the place where you cannot completely remove it, then you have to go with radiation therapy for a complete clinical remission. So other few treatments that have been described are intralesional triamcinolone, which I haven't used, so I don't know how best it is giving results. So in case of incompletely resected or non-resectable tumors, so intralesional triamcinolone has been used with better results. And for disseminated lesions, oral prednisolone 2 milligram per kg body weight for 2 weeks, then 1 milligram per kg per day for 2 weeks, and then 1 milligram every 48 hours indefinitely until you have a remission or until you go for further treatment. So prednisolone can be used, oral doses. Additional palliative therapy, since it is a highly histaminic tumors, you can go with H1 blockers like diphenhydramine. Here we use Benadryl. H2 blockers, you can go with cimetidine, famotidine, and ranitidine, and proton pump inhibitors like omeprazole to decrease gastrointestinal side effects. In case if there is an ulceration or that is evidence, as I was telling you previously, if there is any vomiting or a melena, then you can go with sucralfate. And you can also go with amisoprostol in case if there is going to be any bleeding episodes. So vinblastine and prednisolone treatment has been used for quite some time in treating the mast cell tumors. So it is almost 12 weeks protocols. In one of the protocol, they use vinblastine 2 milligram per meter squared intravenous and prednisolone at 2 mg in the first week. Then on the second week, prednisolone is the 2 milligram per meter squared IV of vinblastine is used for all continuously for 12 weeks. But for the prednisolone dosing, it's first week it is 2 milligram and second week it is 1.5 and then reduced to 1 milligram, which is maintained later on up to the 12 weeks of treatment. In another protocol, prednisolone is used 1 milligram throughout the entire 12 weeks protocol. Single dose of lomustine, single therapy, monotherapy of lomustine has also been used with better effects. 90 milligram per meter squared of lomustine per oral. It is used for 4 cycles. So it is used 21 days and for 4 cycles. So combination is another one. Vinblastine and lomustine. So vinblastine, prednisolone we saw, lomustine we saw separately. Vinblastine and lomustine combination can be used. Vinblastine at 2 milligram per meter squared. So vinblastine dose doesn't change in week 1. Then every 4th week. Lomustine is used at the dose of 60 milligram per meter squared per oral in week 3 and then every 4th week. So this combination has also given as a use. And the another combination is like vinblastine, lomustine, and prednisolone has also been tried. So here we are using 3 drugs in combination, and again, vinblastine, lomustine, and prednisolone at a different combinations. Like if vinblastine is used in the first week in the first protocol, and vinblastine is used in the third week in the next protocol, with the dose being changed to 3.5 milligram. So this combinations does a better work in treating cases when you don't have access to other drugs, or if the client is okay for this repeated protocols. So now there is a drug which is called as imatinib, that is being used with good clinical efficacy, and we have used it successfully in almost 7 cases. Except in 7 cases, in 6 cases we got a good response, except for one. Here we used tyrosine kinase inhibitor, that is imatinib was used here at the dose of 10 milligram per kg orally once a day for 10 weeks. Along with this, we used prednisolone at a dose of 1 milligram per kg, SID orally for 3 weeks. That is followed by a tapering dose of 2.5 milligram per kg in the 4th week. Chlorpheniramine maleate at 3 milligram per kg once a day, and famotidine at 0.5 milligram per kg BAD were also added. In case if the dog is going to vomit, then this is very difficult to be given. So you have to consider the clinical signs in the dog. So which one to choose is also in your hands based on the lot of protocols that are available for mast cell tumors. So we have used this one. These out of these 7 dogs, none of them had vomiting episodes. So they had a very good response. So we used it. Only thing is the side effects were thrombocytopenia and anemia and ulcerative gastritis, but during the course of the treatment, which improved later on. So these were the few cases that we used. Here you can see there was extensive in the ventral abdomen, and here in the leg, here on the sides of the leg, which improved after the treatment. So tosiranib phosphate, as Pallada from Zoetis and tosirapid from Vivaldis are into the market, and which are giving a better results in the treatment of mast cell tumors. Again, they are also coming under the group of c-KIT inhibitors, that is tyrosine kinase inhibitors, and initial dose recommended is 3.25 milligram per kg body weight orally every other day. So if you're giving today, tomorrow you're not going to give, the next day you will be giving. So it is like alternate days or every other day. And they are giving a promising results, and you need not have your client coming for injections every day. So you can go with tosiranib as a monotherapy, and tosiranib can also be used with the vinblastine. So vinblastine here is used at the dosage of 1.6 milligram per meter square every other week, concurrent with tosiranib at 3.25 milligram per kg per oral every other day. So this combination can also be chosen by you if you want to combine these 2 drugs. So masitinib, again, this is one of the other drugs which are also used effectively in the treatment of mast cell tumors. It is used at the dose of 12.5 milligram per kg per day per oral until you get a clinical remission. And if the drug is not tolerated, you can reduce to 9 milligram, and even up to 6 milligram you can reduce the dosing. So you can use masitinib in the treatment of canine mast cell tumors. And one of the biggest thing that has come into the market is Stelfonta. It is TG Lanol TG late injection. This is a injection that is available for mast cell tumor. This is for lesional injection at the tumor site, but it has not come into our country, but it has been approved for use in USA. So it is one of the drug which is injected at the tumor site. Here, because we are going to inject anti-tumor drug at the injection site, we need to go for a sedation. and we need to shave the hair. Tumor surface should be intact, because if you are going to inject the drug, it is going to come out if there is going to be any ulceration. So if there is going to be any biopsy which you have taken, the drug can leak. So you have to measure the tumor volume. So you have to measure the length, width, and height, and multiply it by by half, and you get the volume. And the volume should not exceed 10 centimeter cube. So in those tumors only you can use, and calculate the dose tumor volume into half, ensuring the total dose is not more than 5 ml or 0.25 ml per kg. So this is one of the drug which is being used. You can see how it is being used. It is in a preloaded, it is in a vial which is supplied with the syringes, and you should have a lower lock syringes so that there is no leak in the hub. So you should have a lower lock syringes, 23 gauge needle, at the site of injection, pointing. If you view from the above, it will be like this. If you see the cross section, it will be like this. So you are going to administer on the tumor sites. So where on the tumor cells and which type of involvement you can use this particular drug is, you can use it on the cutaneous mast cell tumors located anywhere on the body. It should be cutaneous. If it is subcutaneous, it should be located below the elbow and the hock. So you are not supposed to use, if it is going to be subcutaneous, above these regions, because it might cause sudden anaphylaxis, or sometimes even because of mast cell degranulation, it might cause even death. So this is one of the drug which is available in USA. In quite some time we may also get to use it here in India. So this is one of the newest into the market, apart from our tyrosine kinase inhibitors. And coming to papillomas, you all know, like if it is going to be single or solitary, we can remove it surgically or cryosurgery, which can help. Important histopathology lesion is like they are going to have coelocytes, which is typical for the presence of papilloma. And here in our country, we use Tuja oral drops combined with Tuja skin ointments, which we have also tried in many dogs, which have given successful results. But sometimes they don't respond, and sometimes they are very aggressive. And we have also used 5% imiquimod cream, which is also good in regressing the lesions. Salicylic acid and lactic acid external application has also been good, but as I said, if it is being applied on the normal skin, it's going to be very highly irritant, and you will get a lot of inflammatory changes in the normal skin. So homeopathy treatment is giving better results. If it is a long standing, then you may have to look for the alternates. So this was after Tuja giving Tuja oral and external applications, the marshals started to shrink. So this is before and after treatment in the foot lesions. So as I said, you can go with surgery, cryotherapy, or laser ablation. We can also go with azithromycin 5 to 10 milligram per kg per oral every 12 to 48 hours. Oral retinoids like acetretin 0.5 to 1 milligram, which is available as 10 milligram and 25 milligram capsules, can also be used in case of canine inverted papillomas. So they have given better results in this. Injectables, there are available, interferons are available as injectables. You can go with autogenous vaccine, immunomodulating agents like levamisole and thiabendazole can be used. But the efficacy is it depends upon the individuals who have used it as a better. But autologous vaccine, which had been used in few of the cases, had been showing little bit of anaphylactic changes in small animals. So we have not used with the autogenous vaccine. A new recombinant canine oral papilloma virus vaccine is also available, but as in general practice, we don't have it for a routine use. Coming to the cutaneous transmissible venereal tumor, it is a malignant, benign to malignant, and you cannot take it lightly. I give an injection, it went away. It cannot be like that. We have to monitor these dogs periodically because they are likely get malignancy also. So it can be diagnosed very well using FNACs with your routine diffuse stains. It has a single nucleus, basophilic and vacuolated cytoplasm. You can see a lot of vacuoles. This is a magnified one. This is what we routinely see on our cytology slides. Here you can see the mitotic figures. So aspiration biopsy of the spleen in one of the metastasized also showed metastasized cases also showed this vacuolated cytoplasm and large round nucleus. So in case if it has metastasized into the spleen and liver, it is very difficult to treat them. So this is one of the cases which we had handled. This dog had ocular lesions, and also it also had a systemic involvement. And this is another dog which had a superficial nodules and also a few ulcerated lesions near the anal and the limb. So this was treated with vincristine and a combination of ivermectin. Both have a synergistic effect. So vincristine and ivermectin has been used in one of the dogs here, which had shown a good clinical improvement by fifth week. So treatment options are available, but most often we choose vincristine sulfate. Sometimes in some of the cases, vincristine does not give promising results, and you might be wondering like why vincristine is not working, because there are two types of canine TVTs. One is plasmacytic, one is lymphocytic, and lymphocytic responds well to vincristine, and plasmacytic, some of them they don't respond to vincristine. Then you have to look for alternates. So when comes to alternate, we have doxorubicin, we have cyclophosphamide, we have L-asparginase, we have lomustine, and here in Namakkal we use vincristine sulfate and ivermectin combination, and vincristine sulfate with L-asparginase in those cases which don't give a good clinical improvement with vincristine. So you have a lot of things that are available for the treatment in case of TVT. So there are other options, surgery, radiotherapy. You can also use oncolytic viruses. Immunotherapy is also available. There are also vaccines available. But which is ready to hand is a big question for us. Coming to cutaneous lymphoma, not very commonly encountered in our clinical practice, maybe in a year, in 2 years once, or in 3 years once, we might get few of the cases, but it should be diagnosed properly by taking a cytology and doing the proper diagnostic techniques like biopsies are very important. Even before, if you do a biopsy, you can at least go with the impression cytology. In this particular case, impression cytology itself yielded a very good results, citing that it was a lymphoma. In case of cutaneous lymphoma, there are two types. One is non-epitheliotropic and another one is epitheliotropic. Non-epitheliotropic might be of B cell or T cell. Epitheliotropic is most oftenly T cell lymphomas. So here, if it is a solitary lesion, you can go for a surgical excision. You can also attempt for radiation therapy. You can also go with, if it is disseminated or if it is more diffuse, then you can go with combination chemotherapies like prednisolone, cyclophosphamide, vincristine, L-asparginase, doxorubicin. Here, whatever you do, the prognosis is going to be very poor, and you need to explain the owner that the survival period is between 6 months to 9 months. So you have to inform the owner. So second, other one is epitheliotropic lymphoma, which is also called as mycosis fungi. Here it is mainly because of T cell lymphocytes, and most commonly golden retrievers are boxers and golden retrievers in our country. We tend to get them more. Solitary lesion, surgical excision, you can also go with radiation therapy. Combination chemotherapies can also be tried. Lomustine can also be used as a monotherapy. And coming to other therapy is like PEG asparginase. It is nothing but polyethylene glycol infused L-asparginase. We now into the human market, we get a lot of this PEG asparginase and PEG doxorubicin. Why is then polyethylene glycol infused is like they counter the side effects better. So the drug is made available better, and they, for example, in case of doxorubicin, they bring down the cardiotoxicity to lesser levels. So that is why in human practice they have started using this pegylated liposomal doxorubicin as therapy, and here we have also used lomustine in few of the dogs. As I said, 6 months to 9 months is the maximum period which we can expect. So isoretinoin is also used at 3 to 4 milligram per kg per day. It is also available as 10 milligram and 25 milligram capsules. It is oil-like capsules. It improves the clinical signs. Interferon can be used. Again, the availability is question. Safflower oil improves the like clinical signs. It gives a better relief for the clinical signs. So safflower oil can be used in the food for the treatment. Apart from that, these are the PEG L-asparginase and doxorubicin that are in the market. Isoretinoin and interferon combination are also being used. Lomustine are used at the dose of 60 to 70 milligram per meter squared orally once every 3 weeks. So it can be used as a monotherapy. Apart from that, your general lymphoma protocol can also be applied for this cutaneous lymphomas. Your CHOP protocol, COP protocol, LHOP protocol, LOPP protocols, LAB protocols, LPP protocols can be used. These protocols are all already being discussed in the lymphomas. So you can use any of the protocols which is comfortable for you. So apart from that, masitinib, which is again a tyrosine kinase inhibitor, can be used. As I told, the starting dose is 12.5 milligram per kg every day until you get a clinical remission. Can also be tried in epitheliotrophic lymphomas. Coming to histiocytomas, this is again a small lesions that are occurring in young dogs, and they are usually um, uh, with the age they tend to cure on its own. Here, they are round cell tumors. You can see they have a very good eccentric nuclei, and it, if you need, you can treat it. Otherwise, you can just leave it to the owner's choice, or if they want to insist on the surgery, you can go for a surgical resection. This particular dog, the owner wanted to go for a surgical resection, so hence we went with a surgical resection. And these are the few histiocytomas which we had in practice. So histiocytic sarcomas, you can see the vacuolated ones, cytoplasm, and you have a large round eccentric nuclei. You can see few phagocytes, leukocytes and erythrocytes in these cells, and darkly stained nucleus you can see in these cells. Coming to the treatment, you can go with the lomustine. Lomustine you can try at 70 milligram per meter squared. The range is between 60 to 90, so better choose a 70 milligram per meter squared every 3 to 4 weeks for 4 doses. So this is for histiocytic sarcoma. In case of histiocytoma, if you want to go for a treatment, you can go with vincristine or even doxorubicin if the client looks for a chemotherapy than a surgical resection and they don't want to wait. So you can go with other chemotherapeutic protocols. Coming to melanomas, melanomas are a big challenge in human practice, and they have started using mobile-based app even to make a early diagnosis of melanoma in humans. So that is malignant melanomas. So in case of benign melanomas, it's like nothing big to worry about it. So if needed, you can go for a surgical resections or you can go for external applications. So in case of malignant tumors, you can see the darker pigmented melanocytes in the cells. So in case of melanoma, which is benign, you can go with imiquimod application, that is 5% imiquimod on the melanoma so that it can reduce the lesion. And there are also oral medications that you can use as 2.6 to 2.9 milligram of tosiranib, which can be used orally on every other day. In case of malignant melanomas, generally we go with radiation. So post-radiation, you can go with temozolomide, which is used at 60 milligram per meter squared per oral for 5 consecutive days. And you have to check them regularly if there is any remission. And if it is incompletely resected oral melanomas, because these oral melanomas also tend to come into the cutaneous places. So you have to go for chemotherapeutic agents like cisplatin or carboplatin. Uh, in case if they are not properly resected or if they are even going for a radiation therapy. Coming to the other drug which is available for use as an immune checkpoint is the latest drug, that is uh, GIL-V. Gilvetmab is one of the monoclonal antibody that has received an approval for treatment in dogs stage 2 and stage 3 lymphomas. It is a commercially available immune checkpoint inhibitor in veterinary medicine. It is available as 10 single use 3 ml vials at a concentration of 20 milligram per ml. And dosage is it is an intravenous injections. The dosage is 10 milligram per kg or 0.5 ml per kg body weight over at least 30 minutes. So this is one of the new drug that has come into the market for use of melanoma. And in case if they are going to be in places where it needs to be removed, you can go with uh, cryotherapies. You can go with cryotherapies or you can go with carbon dioxide laser ablations. Cutaneous plasmacytoma doesn't require much of chemotherapy protocols. If needed, if it is in a very difficult place where it requires a removal, for example, in the foot pads or in the places where the animal has a constant friction, then you have to go for a surgical removal. Otherwise, it can be left without much, without interfering much. So most common breed which are prone for plasmacytoma or cocker spaniels, it's not like that. We have also recorded in other breeds. So mostly surgical removal is recommended. So here you can see the nucleus which is in multiples. So these tend to say that there is a uh, like multinucleated cells. So which are also called as flame cells, which for example, the margin of the cell, if it is going to be very darkly stained, then we call it as flame cells. So here in few of the plasmacytomas, you have this kind of appearance, that is a margin of the cell looks more brighter and more predominant, called as flame cells. So this can be seen. And ceruminous adenomas, these are small grayish colored, grayish blue fluid containing structures. These can be left untreated if they are not causing any much problem. But in case if they are going to obstruct the ear canal, then you can go for removal, and mostly with laser ablation. So this ceruminous adenomatosis are being removed. Coming to the references are from the cytology references are from veterinary clinics of North America, and a few of the cytology was also taken from the textbooks. And before getting into the conclusion, I would like to tell, see, one of the things that they teach new physician is the phrase, when you hear hoops, think horse, not zebra. This principle is quite simple. The odds are the patient has the more common diagnosis than a rare improbable one. So, for example, this is a dog with demodicosis. So, when you see at it, even before going for a preliminary skin scraping, you just think of doing a biopsy. It's not worth in spending time on such issues. So, first do a basic skin scraping to rule out whether it is a demodicosis. So just do a small scrape. So don't get into conclusion that it is going to be a tumor. So here it is a tail gland alopecia, and there is a small nodule here, but this is not a big thing to be worried about. But here, if you see, again it is on the tail, but it is going to be a mast cell tumor. So in case if you have a raised lesions like this, then you have to go for a cytology. So in this particular case, it was a sterile pyogranuloma. We did an aspiration. So did a cytology. It was all neutrophils, and this was treated with antibiotics. So we did not require any much um, better things like your chemotherapy to be used, because it was a simple pyogranuloma. So that's coming to the end. Thank you for the Drools. Thank you for AVD. And thank you to my college and my teammates who helped me in getting most of the images. Uh, any questions I would like to take?
Yes. So if there are any questions from the audience, can we please put them in the chat box and I will convey them to Dr. Sumathi. So, Doc, we have the first question. Dr. Vipul has asked how much of the FNAC is advisable in case of a mast cell tumor, because as per his knowledge, it is little scratch can lead to mast cell tumor burst and then anaphylactic shock may occur. Please guide regarding this.
Okay, once there is a mask, there is no option. There are only two options. One, you go for a FNAC, or you go for a excisional biopsy. By looking at the mass, you will not be able to tell whether it is a mast cell tumor, right? So you may have to go for a FNAC. FNAC not always will lead to anaphylactic shock, and so far we have not encountered any kind of anaphylactic shock with a small FNA. So you can very well go with an FNA. Once it is confirmed that it is going to be a mast cell tumor, you can go with a complete resection. So for example, the cases which we had shown to you, they all underwent an FNAC, and I don't think none of them had shown any kind of anaphylaxis. So you can very well go with an FNAC. It will not cause any big danger to the dog.
Okay. Doc, the second question we have is doctor has asked whether there are any biomarkers for tumors or metastasis.
Histopathology is a big biomarker. So HP and FNAC itself is a big biomarker. Apart from that, if you want to go for differentiating, like for example, I told you if it is going to be a plasmacytic or a lymphocytic TVT, and you want to choose a chemotherapy based on plasmacytic or lymphocytic, then you can go with the immunohistochemistry. For example, epitheliotrophic lymphoma and non-epitheliotrophic lymphoma, you need to go with immunohistochemistry. Otherwise, you will not know whether it is epitheliotrophic or non-epitheliotrophic. There are no as such blood biomarkers that are readily available like other tumors. For example, if it is a liver tumor, or if it is going to be a prostatic tumor or something like that. So we don't have much of it in skin tumors as a marker. And I think immunohistochemistry has been playing a big role in uh, differentiating the tumors.
All right. Another question, Doc, is Dr. Manav Sharma has asked how long we can or do we need to continue vincristine in cases of TVT if there is no complete revision seen in after the 4 weekly doses.
See, that's what I said. So if you are going to use vincristine, some of the cases only with plain vincristine will not work until 5 weeks or 6 weeks. In such cases, you can combine them with ivermectin, because those two are in combination. They do a good synergistic effect. They make the vincristine available to the tumor cells in a better way. Otherwise, you have to go and check whether it is a plasmacytic or lymphocytic and why your vincristine is not working. So generally, it is by 5 to 6 weeks they get a complete clinical remission. If not, you need to check whether there is any meds. So you need to check if there is any meds also. Why is it not working? So generally, if you do this, I don't think you will have any problem.
Okay. Doc, another question is, what is the concept behind using azithromycin for papilloma?
Yeah, azithromycin has been used in papillomas for the immunomodulatory effects, not of much big effect. They do have a lot of effects. Here we use it for immunomodulatory properties.
All right. And the last question is can it be, what is the significance of clindamycin in tumor therapy?
Clindamycin, I don't think I have had any use of clindamycin in my practice, so it may not be right for me to answer that one.
And Doc, and our last question is, can it be helpful in CA125?
See, if it is canine specific markers that are available in India, you can very well use it if the company claims it can be done. So if there is a marker that is used for the humans and you want to use it on pets, then you have to think twice for it. So it's always better, no? You check whether it is being used in the veterinary practice, and particularly it is veterinary specific.
Okay, Doc. And the last question is, how long can doxorubicin be administered before its cardiotoxic effects begin to manifest? And is there any dose-dependent correlation?
Definitely, there is a dose-dependent correlation, and if it has to be monitored for every chemotherapy, after doxorubicin is used, you need to check for the cardiotoxicity. So, if you find any signs of cardiotoxicity, you can discontinue doxorubicin immediately. So, it is not that you need to use it because it is in the protocol. So, you can discontinue the protocol, and you can wait until it is being in a better way, or go for an alternative treatments. Other thing is, that's what I said. It is a polypropylene, that is PEG doxorubicin. PEG doxorubicin is being used in human medicine that does not have a cardiotoxicity. So why don't we look into the alternate? Instead of going in with doxorubicin, you can go with PEG doxorubicin.
Great. Okay, thank you so much, Dr. Sumathi, for that very, very enlightening session. Thank you for going into such depth and helping everyone understand. I'm sure everyone really appreciated how much effort that you put into this. Thank you so much.
Thank you, ma'am.
Thank you, Dr. Sumathi, for a wonderful session. You have
Thank
covered
you, sir.
a lot, so elaborately. We are very much happy to hear your involvement and your great presentation. Thank you.
Thank you so much.
Thank you, Dr. Sumathi. I would just like to present on the screen the next few webinars that we have lined up over the next few months, again in association with the IAVD. So please feel free to register once we let out the registration forms and all of it. And we appreciate you taking your time today. To conclude, I would now like to invite Dr. Nilesh to kindly deliver the vote of thanks, please.
Thanks, Dr. Ivanka. Am I audible?
Yes, Doctor. Please go ahead.
I would say for Dr. Sumathi, wow. This one, the webinar, it is full of information regarding real world dermatological challenges. I'm thankful to Team AVD and Team Drools for organizing these series of webinars so that we all are getting benefited and real world problems are being discussed it is just not just a lecture. It is really all the photos are being discussed by Dr. Sumathi very well, and questions being asked by all the participants, audience. They are very, very practical ones. And I am thankful to Dr. Nagarajan sir, who is our mentor or president. I'm also thankful to team Drools, Prerna Kumar, Dr. Ivanka, and all others associated directly or indirectly in this webinar series. Thanks, Team AVD. Thanks, Team Drools. Thanks a lot. Thanks a lot to all of you. Have a nice time. Good night. Bye bye.
Thank you,
Thank you,
Nilesh.
Doctor. Thank you, Dr. Nilesh. Before we wrap up, I'd like to remind everybody in the audience once again to please fill out the form in the Google link that I've pasted in the comment section to receive your certificates. And lastly, thank you all for taking the time to attend this webinar. Thank you to the IAVD and everyone associated with that organization. And again, a big thank you to Drools for giving everyone a platform like this to be able to educate and learn together. Wishing you all whatever's left of the weekend ahead. And we look forward to seeing you at our future sessions. Thank you so much and have a good night.
You know, my friends and I, we talk about everything under the sun. So how can we leave out discussing something as important as our pets and their diets?
Always remember to check the back of the pack when it comes to buying food for your pets.
Make sure that you're feeding only real and clean ingredients.
It is 100% real chicken.
No byproducts
Or fillers.
All natural, all healthy ingredients.
It gives them the best of both, taste and nutrition.
Drools.
Drools. Drools.
Drools.
Drools.
Drools. Feed real.
Fitly.